Hi, I'm Dr. Mark Student, and today we're going to be discussing ranges of motion, hyper versus hypomobility, and is it a valid indicator for future care? But first, I'd like to thank Cairo Secure for the opportunity for allowing me to share this information with you. We're going to go right to the slides. Now, when we look at the issue of ranges of motion, that's always one of the two main go-tos that the carriers look at to determine for the necessity for future care. And is it really fair? Is it accurate? Is it inaccurate? By the way, the other one is usually muscle testing, which is going to be for a whole different topic and a whole different time frame. Now, a little bit of housekeeping. I'm a little bit of a computer nerd. I've got four screens in front of me. I'm going to be reading off a screen right here today. So when you see this side of my face, that's when I'm looking at the screen. Now, when we look at range of motion, it's the chiropractic go-to. It's validation for initial care or extended care, and we use global ranges of motion. Is it 45 degrees in flexion? Is it 25 in extension? Lateral bending? We look at all of these different things in our initial evaluation and our reevaluations to determine if our care is working. So the question is it fair and is it valid? And are there other things that you can do? But first, let's look at demonstrability of ranges of motion. Demonstrable means show and tell. So there is three things that we look at. One is instrumentation or just range of motion. It can be visual or instrumentation. Number two is George's line, when you're measuring the stability of the spine, looking at one type of range of motion, or ligamentous integrity, and the other is X-ray digitizing. All of those determine the ability of motion and the ligaments that hold those segments together, which is the purpose of the range of motion test. Now, when we look at the first, we look at George's line, and we look at this. We see here on the left that if you look down L5, 4, 3, 2, 1, in the back, the bones all line up. But now there's a step off because there's a spondy here with a spondylolysis. That's a step off. It doesn't line up. So therefore, we know that there's a ligamentous injury, and we expect aberrant range of motion. Where if we look at the lines here, anterior, posterior, they all line up, and it's valid and a healthy George's line. The next thing we look at is range of motion with a two-piece inclinometer. Now, many of you eyeball it. That is not a clinically valid test to report degrees. In other words, it's 20 over 45. I eyeballed it. That's impermissible according to the AMA Guides Evaluation of Permanent Impairment, 5th edition, page 400. And if you use the 6th edition, it refers back to the 5th edition for range of motion guidelines. If you're going to report a valid number, you must use a two-piece inclinometer. You must. It can be analog or it can be digital. It could be a cheap JMOR that you get on eBay for a couple of $100, or it could be a fancy one connected to a computer, connected to muscle spasticity and surface range of motion, and all this stuff that costs you $10,000, $12,000. It doesn't matter. It's got to be a two-piece inclinometer, and that's directly from the AMA guides. Now, goniometers are only permissible for extremities, and arthrodial protractors are only permissible to be used as a doorstop in your office because they're thoroughly not acceptable. So remember that. Range of motion, two-piece inclinometer, and that's right from the AMA guides. Now, when we look at global range of motion, and you're seeing too little motion, what does that represent? Too little motion, you're looking at global, from C1 usually to T1. It usually represents muscle spasticity. In some instances, it can represent meniscoid entrapment. We'll talk about that later on, with secondary muscle spasms in the area, which usually happen as a result of the nociceptors and the facets. We discussed this in a different seminar, or the mechanoreceptors firing aberrantly. That's what causes the muscle spasticity in the surrounding area. And the majority of the muscle spasticity is to try to create homeostasis biomechanically, or take a bone off a nerve, or take whatever you need to do, move things around, shy away from the herniation, whatever the body needs to do in an antalgic posture. Those are the different issues and reasons you could have muscle spasticity. Lots of them. So the question is a global range of motion a fair and accurate arbiter of the condition of the spine when you're looking at too little motion? Is that an accurate arbiter of your treatment? And when range of motion comes back to normal globally, are you then supposed to be done with your care? Well, the carriers say yes, because this entire process is skewed towards them. The question is, what is global range of motion? Well, let's look at this example. On the left, you're going to see same person, left and right, but look at this perfectly 45-degree normal flexion. At C5 and 6, there's a fused vertebra. At C5 and 6, it's fused. How the heck can you have normal range of motion with a fused motor unit? How can you do that? Well, let's look at it. If we look at the sample that I created, and I put lines and the angles aren't accurate, by the way, it's put there for academic purposes, but let's look at it here. C1, C2. Between C2 and 3, you've got 6-degree angle between these, 6 degrees of motion between these two vertebrae in a motor unit. That, folks, is normal. But C3 and 4, I have 16 degrees. That's abnormal. It's too much. Then I've got C4 and 5 is 14 degrees. That's abnormal. Then I've got C5 and 6, because it's fused in the front, it's rocking backwards. It's minus 5 degrees. That too is abnormal. But when I go to C6, 7, that's 14 degrees. That's abnormal. It's too much. But when you add all 5 motor units, it equals 45 degrees. But yet 4 out of the 5, 1, 2, 3, 4, are pathological. Now, what are they pathological for? They're pathological for biomechanics. What is causing that biomechanical pathology? Well, we know at C5, 6, you've got fusion. But what's causing the other 4 to be abnormal? The other 3, I'm sorry, to be abnormal? It's easy. The answer is connective tissue pathology. They're moving too much. They've gone beyond their paraphysiological limit. Now, what's paraphysiological limit? I put my hand up, I go to bring it back, I can't go anymore, I'm stuck. That's the paraphysiological limit. If I go more, I'm going to break something, or I'm going to tear the ligaments. Well, in this scenario in the spine, you are tearing the ligaments in the spine. And you have to determine what ligaments are being torn and where. That's connective tissue pathology. And that's a big issue. It's a huge issue, because that will always, and this is an absolute, always, always, always lead to future degenerative problems, arthropathies, not arthritis. That's an inflammation of the joint. And arthropathy, a pathology of the joint. Now, how do I know that? Well, because Julius Wolff in 1859 coined Wolff's Law. And that's what arthropathies is. That's a degenerative process. And with aberrant pressure on that vertebra, you're going to have remodeling of the bone. Not sometimes, but every time in the human body. Non-negotiable. It's a law. So therefore, we know when these bones are aberrantly positioned, they're going to put aberrant pressure, and through the, which I'm not going to explain today, the mechanism, through the piezoelectric effect, you're going to have ionic exchange. It's going to suck calcium, just like you see over here. And then it's Wolff's Law, the bone's going to remodel. And that's just the mechanism behind how it works, which plays heavily into how the chiropractic lesion works and the sequelae. In our formative years, we call that subluxation degeneration. Now, I had a nose-to-nose argument with a professor in one of the chiropractic colleges where I teach. I teach in the University of Bridgeport School of Chiropractic. That's one of the 3 institutions I teach or I'm an adjunct professor at. And we had a nose-to-nose argument. That's all theoretical, mumbo-jumbo, subluxation stuff. Show me the evidence. Well, guess what? Wolff's Law, it's been in the evidence forever. And if you don't like the word subluxation, use the word biomechanical pathology. I don't really care. It's the exact same thing. Don't get lost in your philosophical belief or disbelief. Look at the science. It's all there. All the evidence is in the literature, and it's been known since 1859. It's been around for a long time. Now, when we look at perhaps the bone being aberrantly positioned causing range of motion issues, we need to look at meniscal entrapment. And we discussed this a few months back when we talked about the mechanism. And by the way, if you want to learn more about this in a very detailed letter at teachdoctors.com, take primary spine care 12, 13, or 14. We spend hours going through this stuff. But watch, there is normally placed a meniscoid as a spacer between the facets. When that meniscoid comes out of position, as you see here, it folds. And this is all based upon the evidence in the literature. The facets approximate, just like symbols. The facets approximate. That, by the way, folks, is where your bone on nerve is that chiropractors treat. Right here, that's your bone on nerve. And it affects the nociceptors. It also affects the mechanoreceptors in the joint capsule. Your Pacinian corpuscles, which are your crimp receptors. Your Ruffini corpuscles, which are your restrict receptors. And you've got more nociceptors in the region, all feeding into the lateral horn, up the spinal thalamic tract, through the periaqueductal gray area, hitting the thalamus. It ping-pongs, because that's your distribution center. It hits the prefrontal cortex, the anterior cingulate cortex, the motor cortex, the sensory cortex, the hypothalamus, and a bunch of other areas. It all ping-pongs around until the motor cortex overrides, then it goes for muscles only. Then it goes efferently back down through the thalamus, through the spinal thalamic tract, and then disparate areas. Meaning you might have a problem in your lumbar, but your cervical and thoracic are going to spasm in different areas to create homeostasis biomechanically. It wants to put some curves in there to create homeostatic plumb, which is the least amount of energy used. I'm not going to explain any more of that right now. But what occurs is when that joint buckles, the inferior joint rides up, just as explains here, on the superior joint, and it buckles. So therefore, you are getting aberrant range of motion. Aberrant. Now, what occurs is you're having hypomobility, too little range of motion. We're talking at the motor unit, which will be affected at the gross range of motion, but you might have other motor units compensating, just like here, too little, too much, too much, too much. But if you look at the motor unit, that meniscoid that's out of place causes hypomobility. But now if you recede that meniscoid with a chiropractic spinal adjustment, because it separates the facets, the meniscoid can go back in, it can instantly either become normalized, but more likely you will see a level of hypermobility if the joint capsule is damaged. Now, in car accidents, I'm telling you empirically, I don't have this from the literature, that a minimum of 70% of every single car accident causes joint capsule damage. Same thing with any other types of sports injuries, and on, not for today. So you're going to see hypermobility because that ligament is overstretched, and that's called laxity of ligament. And I'm not talking, for those who understand personal injury, I'm not talking AOMSI. I am talking pathology of that ligament. Primary, secondary, or tertiary, which we don't see in our office, primary or secondary strain sprain. So therefore, the only way to diagnose this, demonstratively. So if you want to look at getting more treatment for your patient that they need, you need demonstrable validation of those mechanoreceptors being screwed up in the joint capsule. And the only way to do that is X-ray digitizing, to diagnose laxity of the ligaments. It's the only way. And you'll be able to diagnose specifically by name the facet capsule, ligamentum flava, anterior longitudinal ligament, posterior longitudinal ligament, atlantodental ligament, supraspinatus ligament. All of these things you can demonstratively diagnose by name, all of them, based upon using X-ray digitizing. Hypermobility, demonstratively diagnosed, is biomechanical pathology, folks. And that is the necessity for continued care, if you could show it to be present. Now, we need to take X-rays. So you need to have demonstrative diagnosis and reporting of those biomechanical lesions. Now, many of you call those biomechanical lesions vertebral subluxation complex. I don't really care what you call them. I really don't care. And it's an issue in our industry because half the schools mandate using vertebral subluxation and the other half the schools throw you out if you even breathe those words. They proverbially, like persecute you, prosecute you, whatever the word is. And that's absurd. We need not run away from our history because it's quite rich in coming up with a lot of answers that society needs. But we need not be afraid of evolving into something that's accepted across the board in every industry. And I can tell you, in my formative years, being a ultra subluxation only and nothing else in my world chiropractor, and talked only vertebral subluxation complex, you know how many medical doctors work with me and referred to me and communicated with me? Zero, zip, not a zilch. Now that I talk biomechanical lesions, hundreds are working with me now and talking to me and asking me for solutions. It also requires X-ray. Now, let's talk about X-ray. Despite a non-patient-centered chiropractic political rhetoric, diagnostic spinal X-rays have zero zippity-doo-dah negative effects. And that's not my opinion. That's right from the evidence in the literature in 2009. But if we move on to the evidence in the literature, and we look at the American College of Radiology and their 2020 appropriateness criteria, they say adverse health outcomes of radiation doses below 100 millisieverts are not shown by the evidence. And this is according to Metler in 2008. Radiation exposure to a patient from a plain film is 0.2 millisieverts, 100 is normal, in cervical, 1 in thoracic, and 1.5 in the lumbar. Among humans, there is no evidence of a carcinogenic effect for acute radiation of doses less than 100 millisieverts. You know what that means? It would require, and by the way, radiation is not cumulative, in a single encounter, 5,000 cervical x-rays, 100 lumbar x-rays, and 50 lumbar x-rays in a single encounter. And if you do more than 50 lumbar x-rays or 5,000 cervical in one encounter, your incidence goes up to 1 in 100,000, which is still minuscule. Radiation is dangerous. You're going to have problems. It's accumulated. I had it already. It's all nonsense. It's not supported by science at any level. And I'm not going to get into more of this at this point in time, but a certain level of radiation activates the anti-cancer drugs, which is proteins or things that the human body produces, and I'm not going to get into that right now, but I just want to let you know x-rays in your office are safe. So what we're doing is we're measuring motor units, and we're digitizing, and this is from a piece of technology called Simverta, which is probably one of the most advanced x-ray digitizing platforms in the industry. That's incredibly simple to use. You digitize, or you just place the corners of the vertebra, plus a piece in the atlas and the occiput. Then what you do, in this particular case, you have posterior arch of the atlas and anterior part of the odontoid. You are measuring atlantodental interval, which you cannot eyeball. You need to do that on flexion extension. This morning, a doctor called me up and said, I did this on a teenager, 15 years old, who was in a sports injury. He was having terrible headaches. Nobody could find anything. His ADI interval was 4.3. You know what I did? Didn't touch him. Sent him right to a neurosurgeon. Didn't touch him because that is tremendously unstable. And you know what's behind the atlantodental interval is the dens, and behind that is your brainstem. Don't touch. So he knows right away that there is a transverse atlantodental and alar ligament that's unstable and impaired. Then we did if we do a flexion extension scenario and we look at flexion extension, you've got 3 lines. I'm not looking at impairment rating. That's an administrative award based upon the AMA guides, 4th, 5th, and 6th edition, depending upon your state. The blue line, and we looked at almost all we could find in the literature going back about 30 years. And what we found is the best representation of pathology is 0.78 millimeters of translation. There's not a lot of leeway there. And there was a plus or minus standard of deviation of plus or minus 22. So we've gone to the most conservative side of plus, and we feel that ligaments impair or have pathology at this level right here at yellow. So we go to the highest end of standard of deviation. So this person at C5 has 2.19 millimeters of translation. And at C6, there's 1.21 millimeters. So I brought this to a neurosurgeon, and I said, you know the non-specific back pain cases you get, which is 99% of the people you see? He goes, yeah. He says, we sent them to PT. I said, first, if physical therapy versus chiropractic is the first provider, there's a 313% evidence of disability versus chiropractic. We get 313% better evidence or get them off of disability than PT does. It doesn't stand the chance. But I said to the surgeon, this is non-specific back pain. The problems are coming from C2, mostly from C5, and a little bit from C6. This is extremely specific. And then I went to angular deviation. And by the way, I really screwed this one up. I have lumbar images here, and I put a cervical sample here. Shows you how smart I am. But nonetheless, say this was cervical. C6-7, it's 17.9 millimeters. And by the way, the surgeon looks at this and says, oh my goodness, I can't use an artificial disc. That changes my prognosis and treatment plan for this patient. I have to change what I do. Now, surgeons all over the country are sending their patients to chiropractors who have this type of technology and credentials. And you need credentials from Spinal Biomechanical Engineering, which is a course at teachdoctors.com, which is recognized from the State University of New York at Buffalo Jacobs School of Medicine and Biomedical Sciences, Office of Continuing Medical Education for postdoctoral medical graduate education. So right away, the surgeons has a peer relationship because our doctors have medical school training, and you can do that too. But you say that there's no fracture, no tumor, no infection, no herniation, and you got this, we know exactly where the problem is. It's in the supraspinatus and infraspinatus ligament. We know how to fix that. We know how to work with that patient to stabilize the spine, because all the surgeon can do is drug them up to shut them up. And you can never have a pharmacological solution to a mechanical problem. Simple. The other thing we'll do in Symverta, we'll give you a roadmap of where and how to adjust and when to adjust. Anything that goes beyond 2 standards of deviations. As you see, this goes to the left, you adjust it to the right. This goes to the right, you adjust it to the left. And on and on and on. And when you're treating a patient and when you're reporting to a carrier, it's very simple. Here is your individualized, demonstrable validation of biomechanical failure. You're going to get paid. What are they going to? The only thing that's left for them to say is, we're not going to pay just because we don't want to. That's the only reason they're not going to pay. We don't want to. That's all that's left. So therefore, what you need to do is validate it demonstrably. It also prevents lawsuits because the carriers are coming after you for predetermined treatment plans. Demonstrability is what you need to do. And you get language in these reports which say, this injury has created connective tissue pathology of the intraspinous and supraspinous ligament, facet capsule, ligamentum flava. Here's your impairment rating. Here's your diagnoses. These are the things that validate what you do, and critically important. Now, before I finish up, I just want to share with you that I just gave you the basics of probably 6 hours of education. I packed a whole lot of information in a short amount of time. So you really need advanced education on this stuff. You can't live in the soundbite world. We call that the old Chiro one step, two step. You know 10%, but profess to know 200%. That's what has kept us down in utilization and has prevented us from having peer relationships. It's your credentials. If you want lawyers to work with you, medical primaries, medical specialists, urgent cares, emergency rooms, you need real credentials that are co-credentialed through both medical and chiropractic academia. These are the things you need to look at. Range of motion globally, the odds are stacked against you. The second you adjust that patient and you recede that meniscoid, you're going to go to normal or hypermobile in a nanosecond. 2, 3, 4 visits, you're done. Those spasms are gone. That's why the carriers want you to do that. The odds are stacked against you. So listen, I'm Mark Student. It's been my pleasure sharing this with you. I look so forward to doing this with you next time. We got so many more things planned. Thank you so much and have a great day.